Ladies and gentlemen, welcome to the world of everything you wanted to know about series but were afraid to ask. This is sponsored by Pradhan Dental Center, and our focus is going to be talking about everyday problems with the relevant specialists in their field that will talk about the problems that we face in our lives in the medical field, specifically related to dentistry. And joining me on this program will also be somebody who will be helping me with the podcast, that is Dr. Siddhant Pradhan.
So this right here is our love seat or hot seat, depending on which way you want to look at it, where our experts will sit, maybe some of them in hot water, and we will try and make them tremble.
Ladies and gentlemen, welcome to the first episode of the Everything You Wanted to Know podcast, but were afraid to ask. It's very exciting to talk to you with our distinguished panel of guests about today's topic is going to be everything you wanted to know about anti-resorptive therapy but were afraid to ask. And in our distinguished panel today, we have Dr. Nikhilesh Borkar and Dr. Siddhant Pradhan. I'm your host, Dr. Siddhant Pradhan. So first of all, let me introduce to you Dr. Nikhilesh Borkar, who is the consultant surgical oncologist at the HN Reliance Hospital in Gurgaon. Also an NCH in Tata and DNB in surgical oncology. He's FEBS surgical oncology, FEBS breast surgery, MNA, MS, MRCS, FACS, FAIS, and very many fellowships in head and neck. He's also a consultant in the Department of Surgical Oncology, specializing in breast cancer and oncoplastic surgery, and also a specialist in head and neck cancer in HN Reliance Foundation Hospital, Mumbai. So welcome, Dr. Nikhilesh Borkar. Thank you for joining us here and sharing your very important knowledge with us.
Thank you for the kind introduction, sir.
And the other guest on the panel we have is Dr. Siddhant Pradhan, who is representing the dental part of bisphosphonate and Denosumab anti-resorptive therapy protocols. Siddhant has an MDS in oral surgery, oral and maxillofacial surgery from Mumbai. He's a diploma in oral and maxillofacial surgery from the University of Manchester. Okay, he's a consultant oral surgeon with Hinduja Hospital, Mahim, and is also a consultant oral surgeon at the Pradhan Dental Centers, Mumbai. So again, Siddhant, welcome, and thank you for sharing your knowledge with us. So, Dr. Borkar, the first question that always comes to mind is, what are anti-resorptive drugs and why are we using them?
So basically, anti-resorptive drugs are bone-modifying agents, as we call it. So they prevent osteoclast from functioning. The group includes bisphosphonates. The other groups also, like teriparatide or denosumab, may be used, which is a rank inhibitor. So these basically push the calcium from your blood into the bones, making the bones stronger. So the main indications are when we have osteoporosis, that is weakness of the bones which develops with age. Secondly, we can use it if there is hypercalcemia. For acute management, we can use it due to any cause, maybe parathyroidism or calcium. Thirdly, we use it for patients who are having early breast cancer, because many of them need hormonal treatment, which means osteoporosis as a result of that therapy. And also it can be used in metastatic cancers from the breast, lung cancer, thyroid cancer, kidney cancer, where they are used to treat the bony metastasis. And also in rare conditions like osteogenesis imperfecta, it can be used, or Paget's disease, which happens in the widow.
So, can we talk about the bisphosphonates and the other rank inhibitors a little bit separately, and if you could explain to our viewers as to what are the differences in the two, in the drug reactions first of all, and the drug actions first of all, and then what are the differences in their usage in medicine?
So the bisphosphonates are basically osteoclast inhibitors or the anti-resorptive agents. While the rank ligand inhibitors, what they do is they promote the bone growth. The second major difference between the two is bisphosphonates are given either oral or IV form, while rank ligand inhibitor denosumab is given as a subcutaneous injection. The side effects are slightly different because the bisphosphonates, they bind to the pores and they remain for long term, maybe years they remain in the body. While the bisphosphonates, within 6 months they are washed out. So one problem that occurs with the denosumab rank ligand inhibitors is that once you stop the injection, many patients get rebound fractures of the spine, which doesn't happen with the bisphosphonate. But the side effects, because basically it pushes the calcium into the bone, so the blood calcium falls down, and that can cause sudden muscle spasm. Patients get something like myalgia, symptom, fever can happen, which are very less with denosumab. But the problem is you have to take control.
The difference between the treatments which are prescribed for bisphosphonates and for denosumab and the RANK inhibitors, are there certain specific conditions that you will use either one of them, or is it the same conditions that both are being prescribed the same drugs?
Basically, for cancer treatment, for metastatic cancers, both can be used. But in early breast cancers, it is usually the bisphosphonates which are recommended. We don't have proven data that denosumab works. There is one trial which has said it may work but did not show any overall survival. While with bisphosphonates, we have overall survival data where it prolongs the life of the patient compared to denosumab. But sometimes what happens is if someone has a raised creatinine, then we can't prescribe bisphosphonates because they are excreted through the treatment. In those patients, we prefer to give denosumab, the rank inhibitor.
So what you're saying is that bisphosphonates are prescribed for metastasis, for prevention of metastasis in
Early breast cancer.
early breast cancer and in lung cancer.
No, it is only for
early breast cancer.
Others, it is to treat those metastases. The dosage is also different. Early,
Right.
it is given either 3 monthly for 2 years or 6 monthly for 3 years. While in treatment, it is given every 4 weeks. So the dose becomes high. It is 4 milligrams every 4 weeks for 6 months, and then we continue 3 monthly for the next 4 to 5 years.
And what are the conditions that you would use denosumab for? Because I think for us as viewers, it's very important to differentiate between the usage of bisphosphonates and denosumabs for cancerous situations and for osteoporosis situations. Because I think the prognosis and the treatment planning for all of us at the end of it depends very much on these factors.
So denosumab is easier to administer. We don't need an IV injection, especially if the renal creatinine clearance goes below 40. Those patients we cannot administer bisphosphonate. Those we prefer to give denosumab. Someone with severe osteoporosis, denosumab is a better option. Bisphosphonates are the first line drug, but denosumab can be given in second line or with high risk of fracture. Those patients we would prefer a denosumab.
Also, if you could talk a bit about the collateral damage or the side effects of these drugs on the body, and which areas will it affect the treatment of these administration of these drugs?
So one area is dentistry, because if you give bisphosphonates, the jaw has teeth implanted inside with close proximity of the oral mucosa, which has millions of bacteria. So bisphosphonates are basically red flags in dentistry. Because if you give bisphosphonate without a dental clearance, because the teeth are in close proximity with the jaw, with mucosa going into it, and the infection of the teeth or mucosa can easily track into the jaw. And we give bisphosphonates, what it causes, the calcium gets deposited, the infection gets integrated. There can be initial signs like just jaw pain, then the mucosa can just disrupt, inflammation happens, and the last stages there can be sinuses, the bone can get destroyed. So what we say is for dentists, the dictum is no drill without history of the patient. So check for bisphosphonates. Many patients won't tell you that they are taking oral bisphosphonates, and then you end up with problem where you lose the jaw trying to save the teeth or just doing a food extraction.
We're going to have a detailed discussion a little bit later on in the program of what should be the treatment modalities of bisphosphonate, and in case you have osteonecrosis post bisphosphonate therapy, and how to treat that. But at this point, let's let the viewers understand you're one of the few people who I know, because a lot of doctors do not even tell the patients the side effects of bisphosphonates. And that's why one of the reasons why we thought we should do this program was also to educate the general public and any of the medical professionals who may want to know that it's very important for the patient to be informed about bisphosphonate therapy and its side effects. And you're one of the few doctors whom I know who routinely sends patients for dental examinations. When did you start doing it? And are you one of the few ones that are doing it right now?
Not really, everyone had been taught. In fact, I used to write dental clearance, but before giving, no one used to check whether it's given or not.
I know.
And then I saw one patient where I had to remove the jaw and put in a fibula. That's when I started doing clearance for every patient. So it's better, prevention is always better than cure.
Also, it helps if your wife's a dentist and your father-in-law is a dentist. Yes. So that helps, yeah. So it's in the family.
Yes.
Does she look at all your patients?
Most of them.
Okay,
She's trained in dental oncology.
We should have saw her on the podcast as well, then I didn't know that. Anyway, it's great because apparently I'm also, I know his father-in-law very well. We go back a long way, so it's a very small world. So if you're prescribing Denosumab, are there any precautions bisphosphonate you're prescribing? What about Denosumab? For osteoporotic lesions, I know that's not your area of field, but if you could shed some light on that, whether in osteoporosis also you have these, if you're prescribing Denosumab, do you have any restrictions and side effects that we may have to take care of?
The same side effects which occur with bisphosphonates can happen with Denosumab also. The systemic side effects are there, but that is the jaw-related side effect. Previously used to call it bisphosphonate-related osteonecrosis of jaw. But then when Denosumab came, they realized it is also having the same side effects of the dental. So now it is called as medication-related osteonecrosis of jaw. So the precautions for Denosumab also remain the same. Only thing is someone with creatinine which is low, with KT failure, we can give this. Also, those who do not tolerate the bisphosphonates due to the systemic side effects like fever, nausea, body, they just last for 5-7 days. But those patients also can be prescribed this. The only thing you have to beware is because after 6 months, in some studies, it has shown that it can cause rebounds, spinal fractures. So you have to continue Denosumab once you have started or switch over to a bisphosphonate.
Okay, so what you're saying is that Denosumab, if you're using, you cannot just stop it. So it is a dose, if you're giving a parenteral dose, it's once in 6 months.
Yes, 6 to 8 grams subcutaneous.
Subcutaneous, 6 months. And if you're doing dental treatment, and we'll come down to that, but you can do dental treatment with Denosumab. It is not as aggressively anti-dental treatment as say maybe bisphosphonates are.
Especially because the bisphosphonates bind to the bone and they remain in your
Exactly.
body.
So there is deposition of bisphosphonates in hydroxylapatite, and that will cause a disruption of the bone characteristics, and therefore there is a chance for MRONJ, which is medically medicine-related osteoradionecrosis. Let's get Dr. Siddhant Pradhan into the conversation now. Siddhant, can you tell us if you are taking bisphosphonate therapy and you are doing the staging of the lesions, how would you start with staging the lesions, and then we'll talk about preoperative and we'll get both of them.
So if you've seen the way the way the disease progresses, the staging is very simple. Stage 0,
The disease you are talking about
is medicine-related osteonecrosis of the jaw. This is post-bisphosphonate or Denosumab therapy. For example, somebody hasn't given you a history of using the bisphosphonate or Denosumab, and I've seen a few cases of this now where the dentist has not a history and done an extraction, for example. 6-8 months later, they come back with a lesion that it looks a little bit strange, but then it's quite clear to most people once you take the history what it is. Basically, so stage 0 is when there's no pain. There's just, you can see a lesion there, but there's no clear break in the mucosa. It's just a small exposure. Anything less than 2 centimeters would be stage 1. and there would be some associated pain but no infection. And it's clear for everybody that you can actually probe the area, and there has to be the presence of a break in the mucosa, the appearance of a bony lesion there, and there should be a fistula that you can actually probe. Anything less than 2 centimeters without pain, that's stage 1. 2 to 4 centimeters with some pain and some sweat and some infection would be stage 2, and anything more than 4 centimeters would be stage 3.
So in stage 3, do you see the involvement of more than just the surrounding area?
It would be a large area as opposed to just a smaller one. 2 to 4 centimeters could be maybe areas of about 3 or 4 teeth, for example.
So again, let's just recap this a little bit, Dr. Borkar, that we are prescribed a patient bisphosphonates over a long. Does the time matter with the therapy? If you are doing it for a year or 2 years or 3 years or 6 years, does it make any difference to the outcomes of the treatment in terms of MRONJ?
Yes, the longer and more frequency or higher dose, the chances of medication-related osteoporosis will be higher. For example, a metastatic patient will get 4 milligram of zoledronic acid every 4 weeks for 6 months, and then we continue 3 monthly. So those are at a very high risk. While someone getting it once a year for osteoporosis, say 5 milligram, even though the dose is slightly higher, but still the chances of getting osteoporosis is less. While someone taking oral tablet every week will again be at slightly higher risk compared to someone taking it once a day.
So, having said that, what would be then, Siddhant, the precautions that one would take in treating? I know that I'm going to put this patient on, and most medical practitioners don't tell their patients. Today, even the general practitioners faced with osteoporosis, and rightly so, are prescribing their patients Denosumab or, in certain cases, bisphosphonates. But unfortunately, the information that they are providing, I feel, is lacking to the patient as to the side effects of that. So if we are faced, and I think both of you all should answer this question, both your specialties, is when you're faced with a patient that you have to prescribe any of the anti-resorptive medications, what would be your advice to the patient?
I mean, the first thing that comes to mind there then is getting dental clearance. And what does dental clearance actually mean? It doesn't just mean that they go have, get everything checked out and do that. But before prescribing anything, the idea is that you have to actually avoid the high-risk procedures. What are high-risk procedures for something like denosumab or bisphosphonates? Basically, any surgical dentistry. So if you're doing extractions or you're placing dental implants or doing something like that, that's a high-risk procedure. Fillings, root canals, you can get away with even when they're on denosumab or bisphosphonates.
So that's the one thing. So what you're saying is that any surgical procedure or even a semi-surgical procedure, you would want to avoid with this. You've explained to us about the staging of the lesions that happen post-bisphosphonate. Let's talk about bisphosphonate or anti-resorptive therapy and its effects on the tissues we have already seen. But what should we look for preoperatively, pre-bisphosphonate therapy, during bisphosphonate therapy, and after the therapy? So let's start with because medical practitioners are prescribing bisphosphonates to you, and rightly so for osteoporosis and other lesions. But they are not informing the doctors about that. So how should we educate them to be able to deliver the therapy at its optimal capacity?
So the most important thing that we need to look at before we start any therapy is that if there's any dental lesions, then any surgical work that is required, any dental surgical work that's required, like an extraction or a dental implant or something of that sort, needs to be done at that moment in time before the drug is started. Because once you start that, then the risk increases dramatically. So that's number one. Any other dentistry like fillings or root canals or something, while they they should be done prior to beginning the therapy. They can be done at a later date as well. However, it's mainly for surgery that we need to do it immediately at that point. And the question then I have to Dr. Borkar is, if you get some time, how much time do you have before you start the therapy?
So if you are starting it for adjuvant therapy, breast cancer, or even for osteoporosis, which is not very high risk, even say minus 2.5 to 0.6 is the T-score, then we can wait for you to finish all the treatment for the healing, we give 2 months, 3 months, and then we can start it. But suppose a patient comes with metastatic disease which has gone to the bone. If I wait for 3 months, you might not have the patient to treat. So that's why those patients we ask, there has to be a coordination between the oncologist and the dentist as to how much treatment needs to be done. If any essential extraction is there, it has to be a non-traumatic extraction without any surgical damage or the thing, so that it heals within say 2 to 3 weeks. That much we can wait. But if it is going to be a surgical extraction, it's better to avoid that for now so that we can at least start that therapy. Maybe after 3-4 injections, we can reassess whether we can do it now and then accordingly proceed.
So what exactly are you looking for? Are you looking for bone healing or just the soft tissue growth
Bone healing as well.
as well? So then it has to be
It's at least 3-4 weeks.
I see.
Do you actually see bone formation in these extraction sockets after if you wait for 2 or 3 weeks, or you don't really
We
care?
don't really wait, but if the soft tissue healing is good enough, then we start.
then the
So
flow
it should not be like first injection and the patient has osteonecrosis also. Before repeated, by the time second third injection, it would have healed.
So what both of you are saying is, let me just summarize it, is that preoperatively, it's extremely important for any doctor to refer the patient to a dentist for evaluation, whether it is bisphosphonate therapy or denosumab therapy, so that any serious dental conditions which may be present, but which may not have any symptoms for the patient, may be identified and treated before you start the therapy. Okay. Secondly, from what Dr. Borkar said, is that in lesions which are life-threatening, like metastasis, then you cannot really wait for the treatment to take place. It has to be done immediately, if at all there is a surgical necessity to do it. But the surgery has to be limited. It cannot be, you can't do implants, for example, but you can only do, say, maybe extractions because of infections and inflammation around those tissues, and then post the denosumab or the bisphosphonate, or for cancer, you want to use bisphosphonate for sensitive times. You do not want any side effects of that happening. So that's the one about the pre-op with anti-resorptive therapy. What happens if a patient comes to us and he's already on anti-resorptive therapy, and let's look at bisphosphonates separately and denosumab separately, because I think that there is a slight difference in the way we look at the patient and treat them. So if you can look at that and tell us during therapy, and then we come back to doctor. During therapy, if the patient has dental infections or trauma and or periodontal disease, what would be your treatment?
So again, you would differentiate then into high risk and low risk treatments. Anything with any exposure of the bone automatically becomes a high risk treatment, because that's where your MRONJ can start from. So you automatically class that differently. So extractions, even if you're doing, say, some periodontal treatment where bone is being exposed, that becomes slightly high risk as well. However, fillings, root canals can be conducted very easily without much of a problem. Even when the patient is on the medication, we don't need to stop it at that point. For an extraction, denosumab, it requires what they call a drug holiday. So it would be about 3 months where the patient doesn't take any injections. And after that, once the drug is almost washed out of the body, that's when you can do the extraction or do any surgical procedure. For bisphosphonates, it's slightly longer. It should be about 6 weeks.
Okay. Anything that you like grab and no carbs?
Very good. One. Yes, sir. Only problem is if we are giving it for metastasis, it's monthly. So that's why we can't give a good. Once that 6 months of course is the acute phase is over, then we can wait for some time, finish the pentagon, and then again restarting. Because then it will be 3 or 6 months later.
Because metastasis is life-threatening, and so that is more important than the fear of osteoporosis. So I think that we have to keep in mind as to what is the eventual outcome of either starting or not starting. And so that's where your risk-benefit analysis comes in. During treatment, during Denosumab or Bisphosphonates treatment or anti-resorptive treatment, what are the precautions? Does the patient have to regularly go to a dentist for maintenance phase? And how do we look at that?
Maintenance phase is critical. You have to have 6 monthly checkups, make sure, or even 3 monthly at times to make sure.
I would recommend 3 monthly for sure.
Just to make sure that there's nothing that's going to escalate into a surgical procedure, which is where the complications sort of set in. If it's just regular, cleaning, for example, or a filling or something of that sort, again, that can be carried out throughout the treatment phase, so there's no issue with that at all. It's only, again, when there's any surgical procedure or there's anything that will cause an exposure of bone.
Yeah, because and that's one of the most important things that we have to explain to the doctors who may be viewing this is that it is safe to treat patients during therapy if you're not doing surgical work. Because people then have this knee-jerk reaction saying, I'm not going to treat because you're taking. So it is not, you're not doing anything harmful to the patient. There are no side effects. In fact, it is important that you will do your maintenance phase even more stringently than you would do for a regular patient. And I think that's something that we will have to emphasize. Do you agree with me on that? And how do you do that with your patients?
So once the patient is started on anti-resorptive therapy, still I would ask them to go to a dentist every 3 months. Because any minor infection which is there, if it is treated, that will in fact prevent the MRONJ from happening rather than causing the MRONJ. Even when the patient is on a monthly bisphosphonate, I would still refer them. So that's the precaution which I tell to all my patients. Instead of 6 monthly, I ask them to go 3.
And if they do find any problems, how would you solve them? In terms of, sorry to interrupt, but there are two kinds of problems. One would be a simple thing like a filling or a cavity or just scaling, which I'm sure you would have no issues with. But what if there is a semi-surgical procedure that needs to be done?
Then we will have to give them a drug holiday, as Sid said. But we will have to stop the bisphosphonate for at least 2-3 months and then let them complete the treatment and another 1 or 2 months for the healing and then restart the anti-resorptive therapy.
Even if the patient is if it has metastasis?
Yeah, because we don't want to push them into surgical treatment for the osteonecrosis. It is better to treat it early rather than wait.
Even if that means delaying your bisphosphonate in a metastatic patient, would you do that, or would you just take a sort of?
It usually will not happen in the first 2 or 3 injections. It will be at least 4 or 5 injections would have gone by the time the MRO is that severe to need any procedure will be done. Otherwise, I will coordinate with the dentist asking, even if it is a severely carious tooth, whether he can do a root canal or some other filling or something which can tide over the time, and then we can go for extraction at a later date. Once the initial 6 months period is over. Well, those taking 6 months, it doesn't matter. I can easily wait for 3 months, do the therapy, and after 3 months is the next injection.
I think that's a very helpful suggestion. So this should be noted because there's a lot of confusion amongst, because there is not enough data available. There is very few, and this is again something that I'm saying, that there is very, very few articles, and of course, there is now a position paper from 2022. We've had position papers on osteonecrosis post,
But that's what's radiation therapy.
yeah. So we've had this from 2009 to now. This is the third position paper. So we are taking a lot of our hints from the position papers, and we've been putting that into our practice. So the last one is post bisphosphonate and RANK inhibitor therapy. How would you treat dental issues?
I mean, essentially, you could go as per normal as long as there's been a break of about for 3 months for denosumab, for 6 months for bisphosphonates. Once that has happened, then you can easily go ahead with all your surgical treatment. There shouldn't be any issues post.
But does that? Shouldn't that matter? The time frame of the therapy. If there is, for example, we know that in bisphosphonate therapy, you're going to have deposition of the bisphosphonates in the bone because of their affinity to hydroxyapatite. So therefore, the healing of the bone is also going to be reduced. You're going to have avascularization of the bone, and I think Dr. Borkar, we will get his help. So how do we plan the therapy in case any surgical therapy has to be given with bisphosphonates? Let's look at denosumab separately here.
So I think your monitoring has to improve post the procedures, and that's the important thing. As opposed to when you would check it maybe once every 3 months or so post a regular extraction, here you'll be looking at it once every month as opposed to that. Just to make sure that there's nothing that can go, no lesion that can form. So your monitoring has to improve immediately after that.
Okay.
So because of early stage now MRONJ which is detected, it is easier to treat than something which is at a later stage. So better safe than sorry.
Yeah. I'm not talking about MRONJ right now. What I'm talking about is treatment. Patient comes to you with a problem and he has undergone therapy and you stop the therapy. How would you then treat the patient depending on the amount of time he's taken is that an important consideration?
At that stage it doesn't, because once the therapy has ceased, then the only factor that you're weighing in is the risk of MRONJ. Other than that, you can treat them like a normal patient.
Correct. So then, I think that explains a lot of the myths that we've had to contend with all along. Because now, with dentists at least, I'm seeing that happening. That just the term bisphosphonates is a red flag, and that red flag is an immovable red flag. Bisphosphonates are not going to treat you, but that is a disservice to our patients who may need even simple treatments are being not given to the patients because of the red flag. Lastly, we come to the most important issue of this, MRONJ, which is medically related oral osteonecrosis of the jaws, which is osteonecrosis of the jaws, which is really the most feared consequence of these therapies. So can you shed a little bit of light on that? The progression of the staging we've already talked about. So can you please repeat the staging, because that was not to begin.
So the staging becomes really important here once the lesion has developed. Stage 0, when there's no clear break, there's no fistula or anything like that can't be seen, no problem. Just maintenance therapy, regular checkups, and monitoring. That's all you need to do. Stage 1, remove any necrotic parts of the bone that are exposed to the environment, because saliva is one of the worst things. The bacteria in the saliva, if that bone gets exposed, can cause an infection, can cause pus formation, things like that. So you remove that necrotic part of the bone, and then again, chlorhexidine vouchers.
Please explain also the stages, because we had said, so just say 1, 0, 1.
So 0 is when there's no break in the mucosa and no exposure of bone, but you can see that there's some sort of lesion forming there. That's stage 0. Stage 1 is when there's less than 2 centimeters of a necrotic part of bone that's exposed to the organ. And at that point, so for stage 1, you remove that little necrotic part of the bone, and then again, maintenance therapy. You will have chlorhexidine mouth rinses, regular checkups to make sure that it doesn't progress any further. Right? Stage 2, you will have to make sure that any sort of lesion where there's pus formation or any infection is taken care of. So antibiotics is a critical thing. Also, painkillers, NSAIDs being prescribed, that's important to provide the patient some comfort. Again, you clean out the area, as much necrotic bone as you can, and again, keep maintenance by cleaning with chlorhexidine and agents like that to keep that area clean. Stage 3 is the difficult one because that's when it turns into a much bigger lesion, which is over 4 centimeters. That's when you have to consider actually resecting parts of the bone. That's why Dr. Borkar will come in and explain that a bit better. When you actually have a larger lesion.
So, yeah, have you finished with your, it's, okay. So, Dr. Borkar, if you could just,
So if it's a large lesion, conservative measures usually fail. Sometimes we have seen patient is not ready for surgery because the surgery will entail removal of the segment of, usually it's in the mandible. Maxilla has good supply, so we rarely see. So we have to resect the segment, and the replacement best part is the fibula, which is one of the thinner bones in the leg after the two bones. So along with the blood supply, the reconstructive surgeon takes it and it's anastomosed in the neck. So it's almost 10 hours surgery to replace the bone. We choose fibula because one, reconstructive surgeons are used to doing it regularly for our cancers. Second, it's a thin bone, so amount of deficit in the leg is going to be low. And even in metastatic patients who more likely due to the higher dose get osteonecrosis. Fibula is a bone which is rarely showing metastasis from any of the cancers. So it is safe in that way. But renal surgery, risk of complications because we have anastomosis artery as well as so what patients will be delivered. That's the last resort. And how almost 96% cure rates for the MRONJ, which is not done with any other thing.
so when we are talking about an MRONJ, what are the rates, you know, what is the rate of MRONJ post-therapy in long term? And because I was looking at all the statistics and there is no uniformity in the statistics. It varies between 0 to about 6%. So depending on the study that we are, so what is your experience, Dr. Borkar? What is the incidence of MRONJ?
When we give it monthly, it's about 5 to 10% patients.
Wow, that's a lot. Yeah.
If data treatment is not done necessarily, if the prophylaxis is done, it comes down drastically. It will be hardly able to, despite doing all that, they can do. Well, once you give it on the 6 month your annual basis, almost about 1% of that too can be given.
One, so 5% is a lot because the 5 out of 100 patients will be suffering from something which is extremely painful and less treatable. Let's put it that way. Because if you're looking at the palliative treatment, then it's basically the patient has to go back to the clinics, get the training done before you get into any surgical treatments. And that is what we would recommend as a first option before the last solution, which is the surgical option. Am I right?
Yeah.
In concluding,
Those are mostly palliative patients. Will they be ready for such a good surgery? That's another question. Because it may not be just bone expert and liver, lung, everywhere. So what are we trying to achieve?
also, coming back to that point, there is a difference in the incidence rates of MRONJ in bisphosphonate therapy and rank inhibitors therapy. So can you please elucidate a little bit on that?
Bisphosphonate therapy, basically because you're giving it more frequently and sometimes higher doses, that's why there will be a higher rate.
And for a longer
And
duration.
for a longer duration as well. That's why there will be a higher rate. So it will be towards 6, 7, maybe 8% at times. Whereas with Denosumab, it will be lower. It will be more towards 5% at the maximum.
And again, coming back to that basic thing, that I will put it in my summary because I think we're coming to the end of that. Will there be a difference in treatment of cancerous lesions and osteoporosis?
There will be. You will probably give lower doses for osteoporosis to begin with, if you even prescribe bisphosphonates at all, because with the way Denosumab works, that's probably a more first-line, first-choice drug for osteoporosis, which again is less harmful for the patient, and also it's a lower dose.
So I think anything else that we would like to discuss on this forum about bisphosphonates? I think we have any questions that you have from the audience.
I have one question. Other than a biopsy, is there any other way that you can diagnose it? MRONJ. It's a clinical diagnosis. There's no other.
I think osteonecrosis and radiographic diagnosis.
radiographic diagnosis.
Clinical and radiographic would be the two ways to diagnose it. If you have sclerotic bone, there is one condition wherein implants which have been placed pre the therapy, when they have MRONJ, you will see that there's sequestrum, the implant is also integrated, and the sequestrum comes out with the implant. How would you treat that? In the same way that you would do the fibula graft, or if it's a larger area?
It's a smaller area with the remaining bone height after sequestering from 1 centimeter active, then you can go sequester, trying to get a tension-free mucosal closure. But if it is a large area, then it will be the same thing. Remove it, resect it, and get it for
So, what is the advice that you would give to dentists whose patients have had implants but are now going on to bisphosphonate therapy?
So make sure the implants are integrated completely before starting any bisphosphonate therapy. So it's like the mobility of the implant, or if you're not integrated, you should not start. Wait for some more time rather than.
What about bone loss around the implants? If there is a significant amount of bone loss, would it be prudent to remove the implant, or would it be prudent to leave it and allow in the future infections to develop around?
It would be better to remove the implant, but again, after removal, we have to wait for another at least 4 weeks or 6 weeks for the treatment. So that's a critical decision where we are also not sure whether to remove or wait for it to be.
So I think what we've discussed today, and anything that you would like to summarize finally, let's start with Siddhant first, and then the best man of the last word.
Just that there's two things that are really important. One is when to do your dental treatment, surgical treatment. And the second thing is monitoring. I think those are the two most important key takeaways from this. You have to do it before the start of therapy. Once the therapy has already been started, then you have to be aware of your monitoring. Those are the two critical things.
I would add that it takes two to save the teeth as well as jaw. There has to be a coordination between the dentist and the oncologist. If they don't coordinate, that the dentist will have not done this therapy, you delay it or something, that's very useful to save the jaw for those patients.
So, Dr. Pradhan and Dr. Borkar, what would be the periodontal guidelines for your patients before, during, and after development of MRONJ during the therapy?
So before, as per usual, 6 monthly that you're doing, again, before the only real consequence is surgical. That's the only thing you're actually worried about before the therapy starts. Once therapy has begun, then you would want to do it 3 monthly. There is a much smaller risk of the formation of MRONJ in patients with periodontal lesions, and that's simply down to any exposure of the bone to the oral cavity. Saliva and things like that could cause infection. That there is your real concern. So you have to make sure that there is soft tissue coverage all over. There's no exposed bone. And that's why your maintenance phase and periotherapy is very important. Your regular maintenance means you're cleaning every 3 months while you're on the anti-resorptive therapy. Post that, again, it'll be the same as while you're on it. 3 monthly would be ideal because you want to make sure that there's no there's no small risk of MRONJ developing after you've already after you stop the therapy, after you stop anti-resorptive therapies.
So you would also prescribe a mouthwash, right?
Don't hesitate mouthwash, first line. And that's where your real maintenance.
And your all your perio aids, like water flossers, like flossing,
Incremental brushes, all of that.
And of course, you can do if it's preoperative, you can always do use lasers to disinfect and reduce the bacterial count. Dr. Borkar, anything to add on that?
Yeah, basically the gingiva or tooth both have direct access to the jaw. So infection anywhere has to be treated before starting with this hospital. Basically the infection or any inflammation in the jaw in the gingiva, which can lead to osteoporosis or cyst.
So, in summary, we've discussed bisphosphonates and denosumab or RANK inhibitor therapy in detail. We've looked at the causative mechanisms. We've looked at the side effects of the treatments. We've looked at the post-operative complications of the treatment. And I think, in summary, let us say these three things. First, whenever you're starting, and this is for the medical professionals, whenever you're starting any of this anti-resorptive therapy, please inform the patient and make sure that the patient does not have a dental. So a dental referral would be imperative for all patients starting, and of course, they will have to be informed. So informed consent is extremely important in this case. Two, if therapy is starting and it's going on for a long period of time, there will have to be a dental examination routinely, and also if there are dental issues which can be sorted out, they should be done if they are non-invasive surgical treatments. If they are surgical treatments, you must then consult with the oncologist, orthopedic surgeon, general practitioners, because a lot of general GPs are now prescribing denosumab and rarely bisphosphonates, but they are doing it for osteoporotic lesions or osteoporosis. And lastly, if you develop MRONJ or medicine-related osteoradial of the jaws, then it will have to be treated by an oral surgeon, preferably, who will then review the treatments that need to be done, either just palliative treatments, either just disinfective treatments, or then surgical treatments. And all of these treatments will have their consequences. So again, information for the patient from the doctor is extremely important, and the communication between the oncologist, orthopedic surgeon, GP, and the dental professionals is imperative. So I hope you've had an informative session, and if you have any questions, you can please send us emails at inquiries@pradhandentalcenter.com. And let me then thank our panelists today, Dr. Siddhant Pradhan, oral surgeon. Thank you for coming and imparting your very valued knowledge. And very thank you is a good one.
Very thank you. So that's very
Very thank you to Dr. Nikhilesh Borkar for having come all the way on a Sunday morning. Probably this is a Sunday morning. So you're all, last night was not a bottom night. So this is Sunday morning. Thank you very much for sharing your insightful knowledge with us and helping not only our understanding, but the understanding of the public.
It was a pleasure.